about the arthrokinematics at the knee. Figure out what an anterior tibial glide will do, or will improve, versus a posterior tibial glide. Anterior versus posterior tibial glide, ideally without looking in the book. We'll confirm it in the book in a minute. Mr. D, can I get you to set up here for one of these? Show of hands, does that improve tibial anterior glide? Does that improve extension or flexion? Okay, so we'll walk through half together, and then we'll take a minute and figure it out again. So first step, if we're moving the tibia on the femur, we're moving a concave structure relative to a convex structure. The concavity is moving relative to a more stationary convexity. When a concavity moves relative to a convexity, the arthro and osteokinematics are the same in the same direction. Take 30 seconds, think about your answer until we all agree. Nobody anymore. Extension? Awesome, agreed. So, when a concavity moves relative to a convexity, the arthrokinematic slide or glide occurs in the same direction as the osteokinematic motion we see. So, if we're just talking about open kinetic chain extension, it'll be my motion, open kinetic chain extension. The tibia begins on the posterior femur. During extension, it ends on the inferior femur. The tibia slides or glides anteriorly on the femoral condyles as the knee straightens out. So our extension is going to, our anterior glide is going to improve extension. Therefore, posterior glide is going to improve what? Flexion, perfect. So we are on 160 left, 160 right column, halfway down, tibiofemoral articulations. The concave tibial plateaus articulate on the convex femoral condyles. Resting position, again, synonymous with loose pack or open or position of comfort, is about 25 degrees of flexion. Here's where you'll see that. If you have a patient who has a really swollen, painful knee, and for the sake of the discussion, let's just say he just had his knee replaced, because those are the most swollen, angriest, painful knees. Just had his knee replaced. And you're there for therapy with him in the hospital on post-op day 1, your patient will not be resting with his knee in full extension, hyperextension. This is not the position of comfort. Similarly, they're not going to be holding their heel to their buttocks in maximum knee flexion. What you're going to find for that patient is that they have a bolster or a pillow under their knees, because this is comfortable. So resting position for the tibiofemoral is about 25 degrees of flexion. Treatment plane we know is peak concavity. And we're gonna jump ahead to 161 right column. And we're gonna do the tibiofemoral anterior and posterior glides. We'll begin with posterior glide, which is figure 550. And you can see the direction of the solid red vector is pushing in a posterior direction. And Haley, are you good?
Mm-hmm.
The whole group now you're reading for, not just your lab. Do a good job. We'll start with indications.
Indications. Testing to increase action. Patient position. Supine with the foot resting on the table. The position for the drawer test can be used to mobilize the tibia either anteriorly or posteriorly, although no grade 1 distraction can be applied with
Pause
the
there.
glides.
Perfect. For your slide glides, anterior is going to be this way, posterior is going to be that way. We can't concurrently apply a distraction. That'd be really difficult to do for this one. So this is going to be one of the times where we don't first distract. It's just going to be anterior or posterior.
Okay. Therapist position and hand position. Sit on the table with your thigh fixating the patient's foot. With both hands, grasp around the tibia, fingers pointing posteriorly and thumbs anteriorly. Force. Extend your elbows and lean your body weight forward. Push the tibia posteriorly with your thumbs.
So with this, the just gave it away. The PCL is going to restrict this motion, right? If we think about the anatomy of the ACL and the PCL, each of them restrict tibial motion. The ACL goes from the anterior tibia to more posteriorly on the femur. And the PCL goes from the posterior tibia to more anteriorly on the femur. Can you guys appreciate that on this side? The ACL goes from anterior femur to a little bit more posterior. And the PCL so can we appreciate, it's a little bit better depicted on the other side of the lab, sorry to everybody here, but can we appreciate how pushing in this direction is going to stress PCL? So this would also be a stress test for the posterior cruciate ligaments. So with your thumbs, this is a little bit deviating from the text, but it'll be helpful next semester. With your thumbs, you can palpate the joint line here and feel just a little bit of posterior movement of the tibia. And then you're applying the force in a posterior direction through the heels of your hand. That was the end of that section, Haley, or is there more?
That was it.
Okay. So we are also going to do our anterior glide from this position. It's not depicted in a picture, it's described in the text, and it's more commonly done from this position. So for the anterior glide of the tibia, which is going to improve extension, we're going to apply a force this way. So essentially, looking at that same picture, just reverse the direction of the red arrow. To do so, I'm going to sink through all of the soft tissue of the gastroc and soleus, right? This is not movement of the bones, this is compression of the soft tissue. So I'm going to sink through all of the soft tissue back there. I'm going to, with my thumbs, palpate the joint line so that I can feel the tibia moving forward. And once I've sank through the soft tissue and I can feel the tibia, that's when I'm going to exert a force toward my body, pulling. Now, one more important detail in this. I'm feeling, with my index finger, his hamstring muscles. I need to make sure he's relaxed. If he's not, if those hamstrings become active, what's going to happen?
It's going to tighten.
Yeah, how do the hamstrings pull on the tibia, and fibula for that matter? Posteriorly. The hamstrings reinforce the ACL. They're the dynamic restraints. They attach to the pes-anserine fibular head region and pull this way. So if his hamstrings become active, I can't draw the tibia anteriorly. So we're palpating for good, relaxed hamstrings, sinking through the soft tissue, and then applying a grade 1 or grade 2 anterior glide for extension. Questions about those two? Well, I have to move. And let me say this, up or down? we'll avoid talking about lateral tilting. Up or down, superior or inferior? How does the patella need to move during flexion?
Flexion, down, down.
Yeah, intuitively we know this, right? Inferiorly. Feels like it goes down. And it should, because the patellar tendon attaches the patella to the tibial tuberosity. And if we take the tibial tuberosity and move it away, the patella has to follow. So again, we're going to pivot to the patellofemoral joint. So we're going to be on page 162, right column halfway down. Begins with the patella must have mobility to glide distally or inferiorly on the femur for normal knee flexion and glide proximally or superiorly for normal knee extension. So we're going to do a whole lot of different patellofemoral mobilizations, but as far as what motions are going to contribute to what, patellofemoral inferior glide for flexion and superior glide for extension. Also, we haven't talked about this yet, but the loose pack or open or resting position of the patellofemoral joints is full knee hyperextension. Full extension. So you'll see there's a little towel roll under the knee on 553. Ideally, that placement should be shifted, and we should have the heels up to put the leg in full extension. And I think intuitively we know this. If you're sitting there, try to wiggle your patella, it doesn't move. What do you need to do if you want your patella to be really wiggly? Ooh. Extend your leg, relax your quads, and now the patella is very wiggly. So for full knee extension, we need to elevate the ankles. So move that towel that's under the knee distally. All right, we are going to be reading under patellofemoral joint distal glide from the very top of 163.
Patient position. Supine with knee extended. Progress to positioning the knee at the end of the available range in flexion. Hand placement. Stand next to the patient's thigh, facing the patient's feet. Place the web space of the hand that is closer to the thigh around the superior border of the patella. Use the other hand for reinforcement. Mobilizing force. Glide the patella in a caudal direction parallel to the femur.
Caudal meaning toward the feet, in other words, inferiorly. For this one in particular, make sure that your forearm isn't vertical, because then we're adding patellofemoral compression. That's not our goal here. We want to do an inferior glide, so we should essentially be parallel to the femur and tibia during this.
Do you want me to read the precaution?
Yeah, go ahead.
I think it's basically
Thanks.
what you just said. It says, do not compress the patella into the femoral condyles while performing this technique. Do you need to
Yeah, perfect.
Wait, can you do that again?
I sure can. Do two pictures.
Yep.
This is the reinforcement.
Okay.
This is without reinforcement. So if inferior glide improves knee flexion, the superior glide in just a moment is going to do knee extension. So we're essentially just flipping what we're doing, taking our inferior hand and providing an upward superior or cranial force directed that direction to improve knee extension. So improve knee flexion and improve knee extension. In addition, there are joint play techniques in every direction that would improve general patellofemoral mobility. So gliding the patella medially, gliding the patella laterally would just be general joint play techniques to improve all mobility. Go superomedial, inferolateral, just all different directions, but those are our patellofemoral glides.
The patella is a convexity moving icon?
The posterior surface, like the anterior, is convex. The femur, if you think about the groove here, this is concave, so it's sitting in there.
Okay.
Generally talk about it in terms of concave, convex though.
Okay. It was just, I was trying to reason through why you did the superior to improve extension. When you said that it glides inferiorly when you extend the knee.
If I said that, I'm sorry, the patella glides inferiorly during flexion, because it's connected to the tibial tubercle. So apologies if I flipped that. Knee flexion and inferior glide are coupled. So if we're trying to improve knee flexion range of motion, we might do a posterior tibial glide or an inferior patellofemoral glide, or the one we haven't yet done at the knee is a distraction. So for this one, I'm going to have my patient sit up. And there's a whole lot of different distraction techniques at the knee. We're going to demonstrate one, but I certainly want to acknowledge that there are others. The distraction we're going to do is on page 161. It's figure 549A. Haley, the narrative is on 160, right column, 2/3 of the way down, under tibiofemoral distraction.
Start at the versus indications.
Right there, yeah.
Okay. Indications: testing, initial treatment, pain control, and general mobility. Patient position: sitting, supine, or prone, beginning with the knee in the resting position. Progress to positioning the knee at the limit of the range of flexion or extension.
I just want to speak to that real quick. So we said that in this course we're going to be mobilizing out of the loose pack position. And the first day I mentioned this, but it might have more meaning now. We don't have to stay in loose pack position forever. If you're treating a really stiff joint, you might decide to put the joint at its point of stiffness at the end of the range of motion and mobilize there. There are other techniques. There's not a lot of absolute rules. So when it says that you can position the joint at different places, that's what it's referring to. Our general starting point, however, is the loose back position.
Rotation of the tibia may be added before applying the traction force. Use internal rotation at end range flexion and external rotation at end range extension. Hand placement. Grasp around the distal leg, proximal to the malleoli with both hands. Mobilizing force. Pull on the long axis of the tibia to separate the joint surfaces.
Here's the challenge here. If I just pull, I'm going to end up getting quite a bit of motion here. So I'm going to either have my patient or somebody else stabilize the femur in an upward toward the ceiling direction, and my stabilization is going to be there while I pull this way. You may also see this done in a very similar position, but with the clinician seated. Either way, I'm pulling the tibia downward toward the feet along its long axis. So if we had a limitation in the direction of knee flexion, we could do a tibial posterior glide, a patellar inferior glide, or a distraction. If we had an extension limitation, at least a passive capsular one, we could do a tibial anterior glide, a patellar superior glide, and a tibial distraction. As you're practicing in the next few minutes, make sure those sync together. This is going to be in the back corner to take care of laser. Is it laser and, or is it just laser? For the stretch chapter. And we're going to be on, you're going to love this next one, pages. We've already addressed the muscles that could potentially limit knee extension. Those are the hamstrings. Our stretch hasn't changed. So we did this the other day. It's going to be identical today. If it's a static, we just hold. If it's a hold relax, we cue our patient to push into our hands.
1, 2, 3, 4.
And if it's an agonist contract, we tell our patient to actively raise their leg up right down. So those haven't changed. Similarly, if we have a muscular limitation preventing us from flexing the knee, it's still the same knee extensor or quadricep muscles that we're going to stretch as in figure 427. I want to add one, though, that's not depicted by a photo. And I'm going to start by asking it, and then we'll work through it in a few moments. In figure 427, we aimed to stretch the rectus femoris in particular, because that was the only one of the quads that's a hip muscle. But what if you believe that your patient's knee flexion is limited by one joint knee extensor muscles instead of the two joint rectus femoris? You should take a minute and work through how you would stretch the vasti instead of the rectus femoris. It's passively insufficient to stretch it, right? And for the rectus femoris, that meant flexing the knee extending the hip and posteriorly rotating the pelvis. To stretch the vasti, we make the vasti passively insufficient, which means what do we need to do? Flex the knee. But we need to make sure to avoid stretching the rec fem. So what do I have to do to the hip?
Flex.
Flex the hip. So the only difference between our vasti and our rec fem stretch is that for the vasti, we're going to have the hip flexed, which shortens the rectus femoris here and allows us to bias the stretch on the one joint knee extensor muscles. Conceptually, we've done that at multiple joints. Are we good? Okay, so 5 minutes to go through the hamstring stretch. It's figure 425. And your knee extensor stretches, which are figures 426 and 427. And also add a vasti stretch and differentiate it.